Okay, let's unpack this, that really uncomfortable feeling down below scrotal pain and swelling. It's definitely something you need to know about for your MSRA.
Absolutely.
And today we're diving straight into epididymo-Orchitis.
Exactly. Epididymo-Orchitis. It's inflammation and infection of the epididymis, that coiled tube behind the testicle, and often the testicle itself.
Orchitis, right.
Orchitis, yes. Think of it as a double whammy of discomfort down there, and, well, understanding it properly is pretty key for your exams.
So our mission today is to grab the crucial info about epididymo-Orchitis from our notes, make it really clear for you.
Make it stick.
Yeah, make it stick so you can nail those questions. We know medical stuff can feel, overwhelming sometimes, but we've got a friendly, structured approach planned.
Okay, so let's start with the definition again, just to anchor it.
Good idea.
As we said, it involves both the epididymis and the testicle. And that leads to those main symptoms, pain and swelling in the scrotum.
Right. And what usually kicks it off?
Often it's infections. Infections making their way up from the urinary tract or the genital tract.
Okay.
And the big ones to remember here are STIs, sexually transmitted infections. Things like Chlamydia trachomatis and Neisseria gonorrhoeae. Very common causes, especially in younger men.
Got it. STIs are a primary driver. Now, what else can sort of get the ball rolling here? Let's look at the etiology, the different causes.
Yeah, the causes are quite varied, actually. You've got bacterial infections, often linked to UTIs, or those STIs we just mentioned. That's common. But don't forget viruses. Mumps is the classic example you need to know.
Oh, yeah, mumps, not just the face.
Exactly. It can definitely affect the testes. Then you have some less common bacterial causes, like extrapulmonary TB, tuberculosis outside the lungs, and ureaplasma ureolyticum.
Okay.
And even some non-infectious things like Behçet's disease can sometimes present this way.
Right.
And it makes sense. People with weaker immune systems, immunocompromised hosts, they're more susceptible. And finally, quite rarely, certain medications. Amiodarone is the one often cited.
Amiodarone, the antiarrhythmic. Okay, that's a wide range. You also mentioned acute orchitis specifically before. Is that always part of epididymo-Orchitis, or can it happen on its own with different triggers, perhaps?
That's a really good point for revision. While orchitis, the testicle inflammation, often goes hand in hand with epididymitis, it can occur by itself.
Ah, okay.
The causes overlap, so mumps is a big one again for isolated orchitis. But you can also see bacterial infections, sometimes called pyogenic infections.
Plus forming ones.
Yeah, exactly. Though they may be less common on their own without the epididymis involved. Then there are granulomatous causes, and think syphilis, TB again, and some rare fungal infections.
Granulomas, those immune cell collections.
Exactly. Trauma obviously can cause inflammation. And sometimes we just don't find a specific cause. That's idiopathic.
Right, idiopathic. Okay, lots of potential starting points. Now, thinking about who might be more likely to get epididymitis, what risk factors should be on our radar?
Yeah, if you're taking a history, certain things definitely increase the risk of epididymitis.
Yeah.
Risky sexual behavior is a big one.
Unprotected sex.
Unprotected sex, exactly, because of the higher chance of STIs. A history of UTIs, urinary tract infections, or any sort of structural issues in the genitourinary tract, that also makes someone more vulnerable. And think about medical interventions, too. Recent urological procedures, or having a catheter in place. That can introduce bacteria.
So anything that compromises the usual defenses or increases exposure, are there other specific risks that should ring a bell?
Yes, definitely. Having had gonorrhea before is a known risk factor.
Yeah.
And any kind of instrumentation of the urinary tract, even if it wasn't super recent. And like we touched on with causes, any underlying structural problems in the urinary tract.
Got it. So we've covered the what and the who. Now, how does this actually happen? What's the pathophysiology, like the mechanism?
Basically, it's when bacteria or viruses manage to invade the epididymis and sometimes the testicle too. And this invasion triggers the body's inflammatory response. You get inflammation, infection, the pain and swelling.
And how do they get in?
The most common way is traveling up from the urinary tract. Bacteria from the bladder or urethra ascend. Less often, they might spread through the bloodstream from an infection elsewhere.
That makes sense. Simple enough when you break it down.
Okay.
Definition, causes, risks, mechanism. Now, critical part. Someone comes in with these symptoms. What else could it be? The differential diagnosis.
Absolutely crucial. You have to think about what else mimics these symptoms. This is where you need to be sharp clinically.
Okay.
The number one can't miss diagnosis is testicular torsion.
The big emergency.
The biggest emergency in this area. It's a twisted spermatic cord, cuts off blood supply, surgical emergency. You lose the testicle if you don't act fast.
Okay, torsion first. What else?
Other things. Well, testicular trauma could be similar pain, swelling. A testicular tumor, though that's often more gradual, maybe less painful initially. An abscess, collection of pus down there. A hydrocele, that's fluid around the testicle. Or a varicocele, those enlarged veins.
Okay, quite a list. Any memory aids?
Yeah, a simple one is, remember the T's: torsion, trauma, tumor. Those are arguably the most critical ones to actively rule out.
Torsion, trauma, tumor.
Got it. Okay, so we know what it might be mistaken for. How common actually is Epididymo-Orchitis?
Yeah.
What's the epidemiology like, say, in the UK?
It's actually reasonably common. In the UK, estimates are around 1 in 1,000 males get it each year.
1 in 1,000, okay.
It's definitely more frequent in younger, sexually active men. If you look just at epididymitis specifically, it's about 25 to 65 cases per 10,000 adult males yearly.
Right. And age?
Age-wise, acute cases peak in two groups, really.
Mm-hmm.
Ages 15 to 35 think STIs, and then again in men over 60, where UTIs and other factors become more common. It's pretty rare in boys before puberty.
Interesting. Bimodal distribution.
Exactly. And remember, mumps orchitis, it can affect up to 40% of post-pubertal guys who get mumps. Significant.
Wow. 40%. Yeah. And lastly, testicular TB, it's rare, but because it's rare, diagnosis can sometimes be delayed.
Okay, good context. So for your MSRA, think young guys STIs, older guys UTIs, and don't forget mumps.
Precisely. That's a good way to frame it.
Now, what does it actually look like when a patient presents? The clinical features.
Okay, presentation. The main things are testicular pain and swelling, usually gradual onset over a few days, unlike torsion, which is sudden.
Right, gradual onset.
You'll often find tenderness or swelling focused on the epididymis, often at the back of the testicle. The scrotal skin might look red, feel warm.
Inflamed.
Yep. Patients might also mention penile discharge, especially if it's an STI, and urinary symptoms, frequency, urgency, pain on urination, dysuria.
And usually one side.
Usually unilateral, yes. That's a key finding. If it is an STI, that urethral discharge is a big clue. And remember those red flags for torsion again. Age under 20, really severe pain, super acute onset. Think torsion first in those cases.
Got it. Pain and swelling, usually one side, gradual onset. Any other signs or symptoms to look out for?
Well, while usually one-sided, it can be bilateral in maybe 5 to 10% of cases.
Oh, okay.
Sometimes the patient might recall having UTI symptoms just before the scrotal pain kicked in.
Like a preceding infection.
Exactly. And always ask about recent mumps exposure or vaccination status. For tuberculous infection, it might be different, maybe more gradual, possibly painless scrotal swelling, perhaps with those systemic TB symptoms like fever, night sweats, weight loss.
Right, the constitutional symptoms. And on examination.
On exam, tenderness on the affected side when you palpate is almost always present. You'll often feel the epididymis is swollen, kind of boggy. It often starts at the lower pole, the bottom, and spreads upwards.
Okay.
You might see that urethral discharge we mentioned, maybe a secondary hydrocele, that fluid collection, redness, erythema, and maybe scrotal edema, swelling on that side. And check their temperature, fever might be present.
Okay, a good thorough examination is key. So we've got a likely picture. How do we confirm it and figure out the cause? Investigations.
Right, investigations. First step is always that clinical examination we just discussed. Carefully feeling and looking.
Mm-hmm.
Then to check for infection, urinalysis and culture are essential. Look for white cells, bacteria, and identify the organism if possible.
Urine dipstick and microscopy culture.
Exactly. Imaging is really helpful. A scrotal ultrasound. It lets us look directly at the testicles and epididymis, see the inflammation, check blood flow, and help rule out other things like torsion or tumors.
Ultrasound is key then. Blood tests.
Yep, blood tests too. A full blood count might show raised white cells. Inflammatory markers like CRP could be elevated. Useful backup.
Okay, basic workup. Exam, urine, ultrasound, bloods. What about more specific tests, especially thinking about those common causes?
Absolutely. Given how common STIs are, STI testing is vital, particularly in that younger age group or if the history suggests risk.
What does that involve?
It usually means taking a urethral swab for a gram stain that can quickly suggest gonorrhea or urethritis, and then sending swabs or a first void urine sample for NATE testing. That's the sensitive test for chlamydia and gonorrhea.
NATE testing, okay.
And that urine sample we send for culture will hopefully confirm a UTI if that's the cause. Depending on risk factors, HIV testing might be appropriate too.
Right. And the ultrasound, you mentioned blood flow.
Yes, the Doppler ultrasound is really important for assessing blood flow. Good flow makes torsion much less likely. But, and this is a critical point, if you strongly suspect torsion clinically, don't delay getting the surgeons involved just to wait for an ultrasound. Time is testis, as they say.
Time is testis. Good one to remember. Okay. Any situations where we dig even deeper with investigations?
Yeah, a few scenarios. If it's confirmed to be an STI, contact tracing and screening for partners is crucial.
Partner notification. Important.
Yeah, very. In older men, say over 50, especially with recurrent episodes, you might think about investigating for underlying urinary tract abnormalities. Maybe a post-void residual urine check or further imaging, like a renal tract ultrasound.
Looking for structural issues.
Exactly. If you suspect TB, it gets more involved. Multiple early morning urine samples for TB culture, maybe imaging like an IVU or a CT urogram, possibly even a biopsy. And a chest x-ray is standard for TB workup.
Okay.
If mumps is on the cards, you can check serology mumps, IgM, and IgG levels. And very occasionally, in complex or recurrent cases, or if tuberculous epididymitis is strongly suspected, an epididymal aspiration taking a fluid sample with a needle might be considered, but it's definitely not routine.
Right. Reserved for specific situations. That's a very thorough approach to investigation. So once we have the diagnosis, how do we manage it? Treatment plan?
Management hinges on treating the underlying cause, usually with antibiotics, and providing symptomatic relief.
Okay, antibiotics first. How do we choose?
It depends on the likely organism. If an STI is suspected, particularly in younger men, guidelines like those from BASH often recommend combination therapy to cover both chlamydia and gonorrhea. A common regimen is a single dose of ceftriaxone, 500 milligrams intramuscularly.
The injection.
Yes, plus doxycycline, 100 milligrams twice daily orally for 10 to 14 days.
Okay.
But, and this is really important, antibiotic choice must be guided by the patient's age, sexual history, local resistance patterns, and culture results when available. If a UTI pathogen is suspected, especially in older men, you might use something like a quinolone, like ciprofloxacin or ofloxacin, again, guided by sensitivities.
So tailor the antibiotics. What about symptom relief?
Crucial for comfort. Analgesia is key, simple painkillers like paracetamol or NSIs like ibuprofen if appropriate. Scrotal support, wearing supportive underwear using a scrotal support device can really help.
Elevation.
Elevation, yes. And cold packs applied intermittently can reduce swelling and pain. Rest, especially initially, avoiding strenuous activity.
Makes sense. Supportive care alongside the antibiotics. What about follow-up?
Follow-up is vital. Usually see the patient again in, say, 2 weeks. You need to check they're taking the antibiotics correctly, assess if symptoms are improving.
Make sure it's working.
Exactly. And, crucially for STIs, ensure partner notification and treatment has happened. If things aren't getting better, you need to rethink the diagnosis or treatment.
Okay. And surgery. You mentioned it for torsion. Does it have a role here?
Generally, no, not for uncomplicated epididymo-Orchitis.
Yeah.
But surgery, usually scrotal exploration comes in if you cannot confidently rule out torsion or a tumor based on clinical findings and imaging.
Right. Diagnostic uncertainty.
Yes. Or if complications develop, like an abscess that needs draining, or rarely if there's testicular infarction despite treatment.
So surgery is more for emergencies or complications. Good. Hopefully with the right antibiotics and care, things usually resolve well. Prognosis.
Yes. Fortunately, with prompt and appropriate treatment, the prognosis is generally very good.
That's reassuring.
Most cases resolve completely without any long-term problems.
Okay. But most cases implies not all. What are the potential complications we need to be aware of?
That's right. Complications can occur, though thankfully not that common with proper treatment. Locally, you can get an abscess forming in the scrotum.
Okay, pus collection.
Yeah. Rarely it can affect fertility or lead to testicular atrophy where the testicle shrinks. Some men develop chronic Epididymo-Orchitis, meaning persistent pain and inflammation.
Chronic pain.
And in severe, maybe neglected cases, sepsis, a systemic infection, is a risk.
Right. Any difference in complications depending on the cause?
That's an interesting point. Cases caused by urinary tract pathogens, the uropathogens, seem to be a bit more prone to sepsis, abscess formation, testicular atrophy, and developing a reactive hydrocele or chronic scrotal pain compared to the STI-related cases.
Ah, okay. So UTI cause might be slightly higher risk for some of those?
Potentially, yeah. And also, specifically for Mumps orchitis, that carries a known risk of leading to testicular atrophy, subfertility, and sometimes even infertility later on.
Right. The mumps' impact on fertility is well known.
Okay.
So generally good prognosis, but be aware of abscess, atrophy, chronic pain, infertility risk, especially with mumps, and sepsis in severe cases.
You've got it. That covers the main complications.
Well, that has been a really comprehensive run-through of Epididymo-Orchitis. Super helpful for revision.
Hopefully. We've gone from the definition through all the causes, risks, how it presents, how to investigate, manage it, and what might go wrong.
Yeah. So key takeaways for the MSRA. Know those common causes, STIs, UTIs, mumps. Recognize the typical features, unilateral pain, swelling, maybe urinary symptoms. Absolutely rule out torsion.
Absolutely. Know the basic investigations, urine tests, ultrasound, and the general management principles, appropriate antibiotics, supportive care, follow-up. And be aware of those complications.
Maybe a final memory nudge.
How about scrotal pain? S for swelling, C for causes, STU to mumps. R for red flags, torsion. O for orchitis epididymitis, T for tests, urinalysis, US, A for antibiotics, L for partners, P for partners, notify. Pain relief, A for atrophy abscess risk, I for investigations, idiopathic causes sometimes, N for need for follow-up. Bit contrived maybe, but hits the points.
Scrotal pain. I like it. Okay, final thought then. Considering all those causes we talked about, what are the key questions you would prioritize when a patient presents with scrotal pain to really start narrowing it down? Something for you listening to think about.
Good question to ponder.
And for more structured help with your MSRA prep, definitely check out passthemsra.com.
And there's also freemsra.com for great free resources too.
Excellent resources. Right, thanks everyone for joining us for this deep dive into Epididymo-Orchitis.
Yeah, hope that was useful. Good luck with the revision.